Hello everyone, my name is Manasa Kalanadhabhatta and I'm presenting our CHI paper titled Multi-stakeholder Perspectives on Mental Health Screening Tools for Children. Over 17% of US children aged 2 to 8 years have a diagnosed mental, emotional, or behavioral disorder. Actual prevalence rates may be even higher since signs of behavioral problems are often difficult for caregivers to identify at a young age. While most children regularly see a pediatrician, only 1 in 3 of them report that they have sufficient training to diagnose and treat children with mental disorders. Digital mental health tools have emerged as alternatives or supplements to this existing mental health care landscape. The HCI community has developed tools for supporting families in tracking children's development and behavioral symptoms, or delivering behavioral interventions through mobile applications. There is also extensive work on tools to identify behavioral symptoms or screening for disorders, which is what I want to focus on today. An open question about such tools is how would caregivers use them to identify, seek help for, and diagnose early childhood behavioral disorders. In this work, we focus on answering this question by investigating what are the unmet needs and gaps in current caregiving practices of 2 important stakeholders in child mental health, parents and mental health professionals or clinicians. Further, we ask, to what extent can these needs be addressed by app-based at-home mental health screening tools? To answer these research questions, we conducted 2 related studies with parents and clinicians. We used our previously developed screening app, Early Screen, as a speculative probe to contextualize our studies. Early Screen is a gamified at-home assessment for preschool-age children that can be completed on a tablet. It screens children for broad externalizing disorders, including irritability, temper loss, and ADHD. It does this by observing children's reaction to deliberately induced frustration in the form of virtual customers at a bakery who provide negative feedback on the child's choice of cake. The child's responses are video recorded and used to predict disorder risk. Using Early Screen as a probe, we first surveyed 25 mental health practitioners from the American Psychological Association's Society of Clinical Child and Adolescent Psychology. Participants were shown a written description of Early Screen and asked questions about their current diagnostic practices, perceived utility of Early Screen, and potential concerns regarding its deployment. Next, we interviewed 26 parents of young children, both with and without behavioral concerns. Parents were shown a 1-minute video demo of Early Screen and asked about their existing parenting concerns, help-seeking behavior, perceived utility, and concerns regarding home-based screening tools in a semi-structured interview. The interview and survey responses were qualitatively coded and used to inductively identify salient themes. We present our findings grouped by stakeholders' existing concerns and how screening tools can address them, as well as the differences in perspectives across groups. We then distill our findings to identify 3 important design tensions in developing screening tools for children and provide recommendations to balance these tensions. To give you an overview of our findings, we identified 3 major concerns shared by stakeholders. First, parents lack scaffolding for identifying concerns and seeking help. Second, there are limited resources to track and support emotional development. And third, behavioral screening is often based on incomplete data. Parents noted that in contrast to physical development charts for infants, there is no information about what to expect at what age for psychological development. At the same time, clinicians pointed out that there are few reliable and freely available psychometric measures or measures that could be administered at a daily frequency to track longitudinal symptoms. Clinicians also had to rely on incomplete data for their diagnosis, often lacking data from both parents and the school, or other real-world behavioral data outside the clinic. When asked about the potential benefits of screening tools like Early Screen, stakeholders noted the increased access to mental health services, the potential to augment existing data and clinical practices, the ability to make screening more frictionless for children, and to support parents. Participants noted that such tools could increase access to care for underserved communities and would be easy and convenient to use. Clinicians noted how such tools could enable clinical applications that are not currently possible, such as observing children in real time and providing live support to caregivers. They also appreciated the ability to more naturally observe children as compared to when they come to a clinic and meet individuals with whom they are unfamiliar. Lastly, parents felt that easily accessible screening tools would support them in their caregiving experience, especially when they might be dealing with their own mental health challenges. Participants also anticipated challenges to deploying app-based screening tools outside the clinic, including their integration with traditional mental health services, building stakeholder trust in screening technologies, and minimizing the potential for harm. Participants wanted clear steps for follow-up if a concern is detected by the app, and clinicians were wary of families not being able to follow up for care. Parents also mentioned the need for a screening app to explain predicted outcomes in order for them to be able to trust it. Participants were also concerned about potential false positives that may cause undue stress, as well as data privacy and security policies of the app. Comparing differences in perspectives across parents and clinicians, we found 3 important points of disagreement. First, with respect to the intentional frustration induced in the Early Screen app, clinicians expressed concerns about leaving caregivers to manage a frustration scenario without clinical supervision. Surprisingly, parents expressed an opposing view. They were highly interested in discovering how their child would react to a controlled frustration in order to potentially gain insight into and improve their frustration tolerance. Many parents were much more opposed to a screen-based interaction format for screening tools, citing concerns about increased screen time and the potential harms of children using mobile or tablet devices. On the other hand, clinicians largely approved of Early Screen's gamified app-based format, which they felt would be engaging to children and could reach a large number of families. Finally, clinicians expressed concerns about screening tools overriding clinical judgment or families not following up with a professional after an at-home screening. However, parents saw value in tools even outside healthcare settings as a way to obtain more information about their child. They also said that if a screening app found any potential behavioral concern, it would make them immediately follow up with a doctor. Based on these findings, we identified 3 design tensions for the development of early childhood screening tools and provide recommendations to balance these tensions. First, there is a need for rich observational data versus limiting burden and exposure. Clinicians and parents want tools to observe a child's behavior longitudinally and in different contexts, both to collect deeper insights and to build trust. However, administering such tools repeatedly may cause additional burden for families and expose children to more screen time. To alleviate these concerns, we recommend designers explore screen-free assessment mediums such as speech and audio, on-body sensors, or instrumented objects for children to interact with. Apps can also enable parental control over the stimuli children are exposed to. For example, in Early Screen, parents could control the frequency and intensity of negative feedback provided to the child. The second tension is between frictionless screening and an over-reliance on screening tools. While child-friendly and convenient screening can empower families by helping them understand when to seek help, screening tools should augment and not replace clinical knowledge and parent intuition. We recommend that developers consider building engaging experiences that center the child's interests and maximize long-term adherence to screening. At the same time, it is important to enable pathways for future care by either including in-app interventions or connecting families to external help in a timely manner. The final tension requires scaling screening tools beyond clinical settings while minimizing contamination and harm. While app-based tools enable convenient, affordable, and accessible screening, observation and inference outside sterile clinical settings may lead to data contamination and raise privacy concerns. We recommend controlling for context by collecting assessment data during specific predetermined tasks that serve as well-validated settings for assessment, as well as measuring possible variability and incorporating it within the screening algorithms. Screening tools must also ensure strong data protections, safeguarding both the collected data and inferred outcomes. To recap, our work looked into multi-stakeholder perspectives on mental health screening tools for children. We surveyed clinicians and interviewed parents to reveal barriers to identifying behavioral issues in children. We investigated how app-based at-home screening tools can support stakeholders and uncovered design tensions that provided recommendations for future screening tools. For more details, you can find the full paper by scanning this code. The authors would like to take this opportunity to thank all our participants and the funding sources that made this work possible. Thank you, and please reach out if you have any questions.